the Brava Plus system, which was released just a few weeks ago, it consists of really four main components: independent movers, self-engaging brackets, the indirect bonding trays, which is how the brackets are delivered to the teeth accurately, and then the last month or so of treatment, finishing aligners. The independent movers are designed to straighten teeth independently and all at once. And what that means is each of those, if you see the square clasp at the top of the arm with loops in it, now each of those square clasps is currently in its passive position in the photo on the right. When it's engaged or stretched to the tooth and engaged in the bracket, it's designed to move teeth over long distances, and not only to move them over long distances, but to move them accurately or predictably over those long distances. I didn't launch. There we go. There we go. That's a little bit better. The clasps themselves consist of two types. There's a standard, which goes on most of the teeth, and then there are narrow clasps as well. The shape memory arms are pre-programmed to move teeth, once again, very accurately and predictably. And notice they're attached to an anchorage base. The soft-coated anchorage base is like an independent platform. It's sort of like if I was on an ice skating rink and my feet were frozen into the ice. So I've got the ability to grab any person skating past me. I can grab them and I can move them. I can in all 6 degrees of freedom with my long arms, if you will. So with my arms, I can grab that person who's on ice skates and I can move them. I can torque them. I can tip them and move them in any direction possible, because I have the ability to independently move them without affecting, in this instance, the teeth next to me. So with conventional braces, where you have a nickel titanium wire that's attached to every tooth, moving one tooth can affect the adjacent teeth. So that's why we refer to these as independent movers. They have the ability to independently move a tooth without affecting the adjacent teeth next to it. And then during the insertion and installation of the device, there's a midline mark which makes it easier for the user during the insertion and engagement process. So how do independent movers work? Once the case is submitted, BRIAS calculates, based on the tooth, each and every tooth, how much resistance, or if you will, what force level is required to move that tooth, and how far is that tooth being moved, and in all 6 degrees of freedom. So based on that calculation, the system selects from a library of arm designs. And each arm design is designed for a specific type of force and a specific amount of movement, knowing that each of these arms has shape memory. So as the device is activated and returns to its passive position, those teeth will move predictably. So in this rendering, we're seeing the device, if you will, the arms. Now this happens to be the previous version of Brava, but it functions just like the Brava Plus system does. And so at that point, it would be inserted into the bracket, and then the shape memory of the arm is going to return to its passive position, bringing the tooth along with it in a very predictable fashion. This is just a shot showing the new Brava Plus clasps. The clasp is what's at the top of the arm, going from its active position to its passive position. And it's moving the teeth gently, just like nickel titanium arch wires do as well. One of the most exciting features is it's designed for comfort. The independent movers have a soft coating because it's on the tongue side. It's tongue friendly, and you get a little glimpse there of the brackets, which we're going to discuss next. But the independent movers are designed to be as comfortable as possible and help the patient get through both the adjustment period as well as be comfortable throughout treatment. So we use this term self-engaging. So what makes the bracket self-engaging? Well, first, there's no clips or gates like you might find on a self-ligating bracket. So there's no moving parts. One of my previous lingual systems was a self-ligating bracket, and it had a lot of problems with the clips. They worked great until they were overstretched, and then it became a problem. And one of the other key features, because we're not using sort of a traditional type of sliding mechanics system with edgewise mechanics on the lingual side, we're using a completely different technology with independent movers, so there's no slop in the slot. And what that means is from day one, all 6 degrees of freedom are activated. So the bracket itself is custom designed to each and every tooth on each and every patient. So and every bracket is custom fit to the tooth. The backside of the bracket itself has an 80 gauge mesh pattern, which makes it as reliable as possible for today's orthodontic adhesives, which are all designed for optimal bonding effectiveness with 80 gauge a mesh pattern. When we look at the brackets themselves, they don't have tie wings. So if you're looking at the bracket on the left side of the screen, we call those mesial and distal tabs. Now, behind those tabs, if you look to the right side of the screen, there's a little dimple, if you will, 2 dimples, and those are designed to receive the clasp once it's inserted. It becomes fully engaged once those 2 dimples are inside of the areas where they're designed to fit. And that's in the vertical slot of the bracket. So behind the tabs is a vertical slot, and that's where the arms, when you deliver the clasp or the arms to the device, it goes through the vertical slot and then becomes fully engaged. There's tooth identification marks on every bracket, and we refer to this as the spring lock feature. So if you've ever had adjustable crutches, or some chairs have adjustable legs, some tents have that spring lock feature as well. So once it's locked into place, it stays in place until you're ready to disengage it. This is a shot, an animation showing how the clasps are delivered to the bracket. And step 1 is to grab it and place it in the vertical slot. And then in a pinching motion, the clasp becomes fully seated or fully engaged behind the tabs of the bracket, where it's going to stay in place until it's time to remove it at the time of debonding, and we'll talk about stage cases here in a minute. If you're moving from stage 1 to stage 2, that's when you would remove it as well. There is a click sound, an audible click sound. It's an audible confirmation that the clasp is fully seated and fully engaged. And as it's depressed down, when you hear that click, you know it's there. For looking at comfort, continue to look at comfort, general continuous forces. One of the benefits of nickel titanium technology is that you can dial in a very ideal force, a very comfortable force. And as the shape memory properties of that metal material, as the unloading force exerts on the tooth, it's a very comfortable force. It's not too heavy of a force, but it's a competent tooth moving force. And over time, that force level stays fairly consistent. So after the adjustment period, from the patient's perspective, it's kind of the doctor sets it and the patient can forget it. And once it becomes passive, the force drops off, and then it's just held in place until all of the teeth reach that passive position. So if we compare and contrast that with aligners, the other aesthetic option, several of the unfortunate features of aligners is they have heavy abrupt forces, and they have a lot of them. So in essence, every time a new aligner is placed, there's an initial heavy force, which drops off pretty quick. But then a week later, there's another heavy force. And so it's a series of adjustment periods as opposed to one adjustment period with the Brava Plus system. Impact on lifestyle. This is probably one of the bigger features of the Brava Plus system for patients who are looking for an aesthetic system. In this example, we're looking at a staged Brava case. And what staged means is that the first stage does about 50% of the tooth movement, and the second stage does the second 50% of the tooth movement. So over in this example, a 12-month case, there's going to be one appliance removal and insertion of the stage 2 independent movers, which takes about 5 minutes per arch on average, is what we're seeing from the reports from those who've inserted and engaged the Brava Plus independent movers. So as compared to aligners, which Once again, it's if it's sitting in a backpack, if it's left in a hotel room, if it's accidentally put into the trash can, it's not going to be moving the teeth. So it's got to be worn, up to 22 hours per day, and so that's up to the patient to control that. And of course, anything that requires compliance can lead to a liner burnout. Whereas with independent movers, it is compliance free throughout treatment. Biomechanics built for speed. So what that means really is faster treatment. And the reason it's faster treatment, at least as compared to conventional braces, is from day one, all 6 degrees of freedom, or all the teeth are being directed and straightened from day one in all 6 degrees of freedom, all at once. And so if we look at those advantages, just to compare and contrast independent movers to conventional braces, all 6 degrees of freedom are listed. You can see the 2 in blue, the horizontal and torque, those are addressed from day one because there's no slop in the slot. It's fully engaged. So from the very beginning, from the first day of treatment, independent movers are exerting a horizontal force, or they're closing space or opening space, and they're exerting torque moments on the crowns and the roots, as compared to conventional braces, which are going through a leveling and aligning phase with the first and the second arch wires. So torque really isn't addressed, and spacing really doesn't get addressed typically until the third wire in most arch wire sequences, where you have enough stability in the arch to start closing spaces or addressing midline correction. So in this example, we're at about 6 months of treatment, and we've got 6 months of torque correction, whereas in the example under conventional braces, we've just introduced the largest or a full-size wire. So that rectangular wire is now starting to exert a torque moment on those teeth for which torquing is indicated for treatment. You're finishing about the time that the torquing is beginning with conventional braces. So once again, in this example, and it's just an example, you can see how efficient tooth movement can be with the Brava system. And there are some patients who are willing to pay a premium for that. They want faster treatment as part of their aesthetic treatment, or they recognize, they're honest with themselves, and they realize they're probably the compliance thing. If they're a relapse case, they didn't wear their retainer, well, they're probably going to struggle wearing aligners as well. So this is a great option for those types of patients. Let's just talk for a moment about the indirect bonding trays and some of the improvements that we've made recently. Our lower trays are segmented, and the reason for that is it controls moisture better, debonds, slow down the treatment appointment. So we're doing everything that we can to help minimize any potential for debonded brackets due to moisture contamination. The upper trays are one full tray segment, but they can easily be segmented should the doctor so choose. One of the unique features of the Brava Plus indirect bonding trays is they have a flat occlusal ledge or surface. So why is that important? Once they're seated, with a visual inspection, you can see if there's any rise or dip in that occlusal ledge, the tray is not fully seated. And that allows the user to make an adjustment before hitting those brackets with the curing light and setting those brackets in place. So that minimizes the potential for brackets being bonded in the wrong position. One of the more recent features that we've made to the tray is when it's time to remove the tray after hitting the brackets with the curing light, there's minimal flash and tray cleanup. And that's important for 2 reasons. One is that extends the appointment time. If you have to clean up a bunch of material, and the flash is because it's a custom bracket, it's a near exact fit to the anatomical contour of the teeth, so not much adhesive is needed. And once you get used to that, there's really very little flash, excess flash to clean up. And then the tray material doesn't tear off, and that's important. Should a bracket ever debond over the course of treatment, you're going to cut that tray and create an individual tooth jig or indirect bonding tray, single tooth indirect bonding tray, and use that to rebond the bracket in place. And you need that tray material to make sure that the bracket is held accurately in place, because that tight fit ensures accurate bracket positioning. And without accurate bracket positioning, tooth movement is not as predictable. So let's talk about the engagement order. It's standardized. So when the appliance is first delivered, the first molars the clasps are inserted and engaged in the first molars. And then after they're engaged in the first molars, you move to the first bicuspids and then to the anteriors. It's sort of a back to front or posterior to anterior, and then you work your way back to the second molars if the second molars are present. Disengagement. Disengagement, you're using the same instrument that you use to engage. Lingual Weingart pliers work great for this. And on the posteriors, you're oftentimes using the crown of the tooth or crown of the molars and the bicuspids as your fulcrum. And then it's just sort of a tilting, lifting motion, and you're guiding, and that guides the clasp out of the vertical slot of the bracket. And this just shows you how quickly that can go on a live patient, where you're just working from back to the front, using either the edge of the bracket itself or the crown of the tooth as your fulcrum to gently guide the clasp out of the bracket. As you get to the anteriors, typically the pads, the occlusal side of the bracket pad is your fulcrum point, and it just gently lifts the clasps out. Once they're all out, the appliance is removed. And then if it's a staged appliance, you would insert stage 2, or you would go to the debonding phase. And speaking of debonding, there is a purchase point on every bracket, on the occlusal side of every bracket, and that's designed just to make it a little bit easier to take the brackets off. And there's more instruments than just this angled bracket removing plier that can be used to debond brackets at the end of treatment. And that concludes a brief and quick introduction to the Brava Plus system. And with that, I'm going to turn the time back to Joe, our moderator.
All right. Get where I'm actually on camera. Here we go. All right. Thank you, Jeffrey. That was great. It's now my honor to introduce our star of the show to give you the clinical perspective on Brava Plus and Brava in general. That second speaker is Dr. Hessam Rahimi. He's in private practice in the Dallas area. He's a diplomate of the ABO. He received his orthodontic training at Harvard University. And then while he was at it, he got a doctorate degree in oral biology. He also is a proud alumnus of the University of Texas, Hookham, where he received his MBA degree in 2016. Dr. Rahimi is one of the first certified Brava by Brius providers. I think he was second or third, but he's the #1 Brava provider in the world, with now having treated over 500 cases. Dr. Rahimi, as I mentioned, is in private practice at Fusion Orthodontics with 2 locations in the greater Dallas area. And he just remodeled his flagship office, and it is beautiful. And what I'm really excited about, he added a learning center, which I do look forward to putting to use. So with that, take it away, Dr. Rahimi.
Hello, everyone. Nice to see you. From Dallas. I have a lot of material to cover, and we had the same presentation last night. It came to my attention that the cases are the best part of it, so I'm just going to skip through, some of the introductory stuff. This is the office, and Joe, by the way, I added some panels. I made it look nicer. So let me tell you a quick history of how I got involved with the company. The first case I submitted was in 2019. And since then, I've now been more than 500 cases. Based on the data that we've collected, about 65% of my cases are over 18 years old, and 35 less than 18. And then probably about 1 in 4 to 5 patients do choose the Brava system. As you can see, I offer 4 options to my patients: the regular braces, clear braces, aligners, and Brava. My introduction with the company comes from by knowing this guy, Dr. Mehdi Peykar. He's the inventor and founder of the company. The concept was very intriguing to me, and that's how I started using it since then. You can see the first prototype of the appliance. It's the appliance is engaged. It's a nickel titanium appliance. Has been engaged to teeth, and this is a wax typodont, and then he's recording the progress. So the Brava is, think of it as a one-piece nighttime appliance that is supposed to move teeth to their final destination. There is a fundamental difference in terms of how the force systems works with Brava comparing to other forms of orthodontic tooth movements. And you can see the summary of it in this picture. When we move a tooth conventionally, the teeth right next to the tooth that's being moved feel the majority of the reactive forces. They want to move again in the opposite direction of the tooth that's being moved. When it comes to Brava, every one that reactive force is broken down into the entirety of the arch. So we don't expect the teeth, left side and right side of the tooth, to move in the opposite direction in general. And then we ran an in vitro experiment, and we ran different scenarios. The summary of it would be clear in this picture that proves the fact that when we move a tooth with Brava, the reactive forces, which in this graph it's in blue, is negligible because it's been broken down to the entirety of the arch, whereas as expected in conventional straight wire systems, the reactive force of the tooth being moved is felt by the teeth, mainly by the teeth right very close to it. Now, this kind of different force system on itself gives us some advantages. But is it safe? That's the first question to ask. We ran a little experiment on about 20 cases of patients treated with Brava from my clinic, with 20 conventional patients treated with conventional brackets, again from my clinic. And we noticed that there is almost virtually no root resorption with Brava. Every single case after case after case, you don't see root resorption with it. The volume loss is about 2% with Brava, whereas with traditional braces, it gets up to about 6%. Even when we adjust the rate of tooth, the root resorption, we adjust it for how long or how much the apex has moved, we'll still see a dichotomy that the Brava system is much less affects the root resorption comparing to traditional. So it's very safe when it comes to maintaining the integrity of the tooth. It helps us with cases that we start with short roots, cases that have bone loss. This would be the appliance of choice in my clinic when it comes to those scenarios. In the same sample, the reason for this reduced root resorption, one could be that the treatment times are generally shorter for the same amount that the apex moves through the bone. In my case, all these cases were non-extraction, and then the Brava cases took about on average 12 months, whereas the conventional braces took on average about 24 months. Another reason that we believe that leads to less root resorption is that there is realistically virtually no round tripping when it comes to the teeth. So if a tooth such as this upper right lateral incisor doesn't have the room to move into, it's not going to push the other teeth around. It's just going to stay there until the space becomes available for it. So in this scenario, as you can see, the upper right central incisor has not budged, whereas the lateral incisor has moved into position, but as the canine is moving distally. So this is a very important factor. So when you have crowding, each tooth doesn't care. It only has one mission, to go from point A to all the way to point B, which we have designed for the system. And then because this is a light force system in general, when there's no space available, when it's blocked, it's going to stop. This is one of the older generations of the appliance. Another interesting factor about Brava is that, as Jeff also explained, is that it makes treatments more efficient. So this is one of the patients I treated, and as you can see, an exploding incisor extraction case is getting treated in about 10 months. We're going to see step-by-step progress of this patient later. But this is all because every one of the teeth have their own separate agenda. They take the shortest possible path from point A to point B. And every one of the 6 degrees of freedom, every kind of movements that we have, this clock starts ticking for all of them right at the beginning of the treatment. Whether it's rotation, tip, torque, buccolingual, occlusogingival, or mesiodistal movements, all of them with the Brava system or independent tooth movement happens right at the beginning of the treatment, whereas with conventional braces, we cannot apply torque or slide teeth until we are on heavier wires. So we do lose a little bit of a time or a lot of time at the beginning for the leveling and alignment of the teeth, whereas with Brava, we don't. And then with aligners, we also know that we have a lot of inefficiencies. We rely on patients' compliance, and we cannot do all movements at the same time anyways. For example, if you do have a slight rotation, the first thing we do have to do is create space for that rotation, derotate the tooth, and then go ahead and close the spaces around the tooth that we have derotated. So we cannot do all forms of tooth movement all at the same time with aligners as well. Independent tooth movement does come with certain features. One of them is that when we do have the teeth are moving independently. Because of that, each tooth by itself can have different rates of tooth movement or could be dealing with a different kind of tooth movement at the time. And that could be different from one tooth to the next. So this has to be discussed to the patient. For example, if you don't, in this case, we do see crowding and deep bite, and within a month after the appliance is inserted, we can see that there's a space between the teeth. There's a bit of a vertical discrepancy between the two. This has to be discussed with the patient. But if you notice, from 1 month all the way to the second month, the discrepancies are getting better, and in about 4 months, is almost completely resolved. And then within 6 months, this entire treatment is completed. So this is one of the features of the independent tooth movement. There are ways or methods to prevent this from happening. For example, if you're worried about the midline diastema to open up, which some patients might like, there are strategies to do that when we're designing the appliances or communicating with the platform with the technicians, which I can talk about later. Independent tooth movement, this is another example. As you can see, the Brava gets delivered, and then suddenly 4 weeks later, we're having these spaces between the teeth. The upper right incisor lateral is a little bit proclined, but these teeth are all dealing with their own individual separate movements. Usually, still the order is about the same. We do see that rotations happen first, correct first, then we get to tipping and space closures. All rotations within 2 to 4 months, expect them to be gone. Vertical movements in about 4 months to 6 months, expect them to be completely corrected. What can take longer sometimes is torque, and then obviously if you have longer spaces, it can take a little bit longer, but in majority of cases, 75-80% of cases, within 4 to 6 months, about 75-80%, 90% of the case is already completed with Brava. The same patient from point number 1 to number 2 to number 3 to number 4, I haven't done anything other than monitoring the case and probably doing some IPR in this open bite case. On the 3rd month of treatment, I introduced rubber bands, but until this point, this lateral upper right lateral incisor has extruded about 2 to 3 millimeters, has actually over extruded a little bit in this case by the Brava system. The reason it's over extruded is because in this case, which I'm going to show you step by step, is the centrals have not come down as much as the lateral. If your patient is dealing with hygiene issues, the best way to deal with it is to go lingual, obviously, because we have a lot of saliva protection on the lingual side. You can treat them without any real long-term consequences, such as scarring of the teeth or bone loss. In terms of, I get asked, like, what cases do you offer Brava to? At my office, I have no, I don't exclude anybody for Brava. I have all 4 options on my table, and I let them choose between the technologies. I've used it in phase 1s, in severe crowdings that needed extraction, surgical cases, open bites, deep bites, cross bites, even some more challenging cases like canine impactions and things of that nature. I have tried them out, but you have to realize that if you're starting out, your best cases would be, if you want to start out, would be your older teenagers, that have kind of like average dental anomaly. Brava is an excellent deep bite corrector. It's able to, by the way, Brias is the company, Brava is the product. I'm used to calling both of them. I hope I don't confuse you, but basically just think of it as tomato, tomato. Brava is very good, excellent at correcting deep bites. So if you have recently, especially, I have these group of adult patients that I'm doing, that they come to me with like a exaggerated curve of speed with severe deep bites. I put a Brava on the bottom on the mandible, and then I treat the top with aligners that the company provides. It's a very good leveler. You cannot level as efficiently, as harmlessly, and fast as you can do with Brias or Brava with any other system out there, whether it's 018, 022, Roth, MBT, aligners. There's nothing comes even close to it. And it's very predictable. I have data that is currently, the article is being written right now, that shows that when it comes to deep bite corrections, the appliance is almost 90-something% accurate. So when it comes to treatment planning in the digital platform, you don't want to overcorrect. You want to plan your vertical corrections as exactly to the degree that you desire. It's an excellent expander. The 97% of what you tell your clients to expand to, Brava is going to expand it for you. So you don't want to treatment plan over expansion. Just expand as much as you need to. Patients that require, that are teenagers or adults that want true discretion, this is probably the most discreet way of moving teeth, because even aligners do receive attachments. Cases that have, but this has nothing unless there's a button put on the outside for any kind of anchorage control or rubber bands. Cases that come with root resorption or short roots at the beginning, Brava is probably the best option because it gives us the ability to, first of all, control the forces. And second, we know that because the forces get distributed and there is no round tripping and there is no, because there's no round tripping and the forces teeth are moving independently, we don't expect to cause any more shortening to the roots. Cases with bone loss, cases with several compromised teeth, asymmetric cases, and then patients that have high risk for caries, probably lingual system would go a long way in treating them. I don't offer Brava if the case is too simple. If the example I use is it's like killing a fly with a shotgun. It really doesn't make that much of a sense. And sometimes when I'm not sure exactly what approach I want to take, if it's extraction, non-extraction, surgical, non-surgical, I don't necessarily offer Brava because I want to be able to see the end point when I'm doing the digital treatment planning. Dr. O'Brien, in his blog, showed up this article that this is a very important factor that I want to talk about a little bit. Aligners are weak in certain kinds of movements. The number ones are extrusions and intrusions. And, we have, not that we cannot rotate teeth with aligners, but it does take quite a bit of a long time. So there's two things that to consider. One is how good the appliance is or the aligners are at doing certain kinds of movements. And then second is how long it takes aligners to achieve those movements. And the third is obviously compliance. All these three, when it comes to the Brava system, are its strengths. For example, we have the ability to level the arch with Brava in 4 to 6 months, no matter how severe it is, case after case. We have the ability to correct all the rotations of every single one of the teeth in 2 to 4 months, no matter how crazy the case is, pretty much, case after case in a very predictable manner. And these are exactly the weaknesses of the aligners. So when I think about Brava treatment, I try to, as Jeff put it with the rocket demonstration that he had, or graphics that he had in his presentation, it makes sense. I do all the heavy lifting with Brava, and I do all the detailing or little things at the end of treatment with the aligners. And this way, I think they make the best couple when it comes to treating our patients. We can offer crazy efficient treatment with excellent outcomes if we just use them smart and use each one for its strengths. There are certain things that I'm going to just run quickly through these. When it comes to case submissions, keep it simple, but have your clear vision of exactly where you want your teeth to be. If it's anything more than a simple case or moderate case, you want to definitely submit it with a CBCT. You want to see your alveolar envelope when you're treatment planning the teeth. There is generally no need to overcorrect, so don't just position the teeth exactly where you want them to end up. Go after all your borders, ABO board standards, level your marginal ridges, correct all rotations according to the criteria we learn in our residency programs, just because you will be able, it's very likely that at the end of the treatment or in a few months, you're right there, with all those specifications. One thing that when you start submitting cases is that you have to understand what auxiliary movements are comparing to the Brava movement. So this is a genius part of the platform, and I believe it's unique to this system. It's able to, we can position the teeth in the virtual world anywhere we like, but the software on back end calculates that based on the biomechanics, based on the anchorage requirements, the number of teeth that are being moved, the number of teeth that are available in the mouth, in that arch, what is possible with this biomechanics. Because all the four systems within the Brava itself, it's intra arch aligner. It's not an inter arch aligner. So think of one Brava as it's going to level, align, and treat one arch, not both arches at the same time. When it comes to upper and lower arch relationships, we have to think anchorage and our rubber bands and things of that nature, TADs if we need to, jaw surgery or growth. But in general, Brava is able to address our needs of within an arch, and then the software is able to delineate between what the software can do, what the appliance can do, versus what where we are positioning the teeth. If there is a discrepancy between the two, it has to be considered and addressed with elastics, with TADs, with surgery, or growth, which the software is able to show it to us. This is a fully customized appliance, so take advantage of that. You can ask for teeth to be moved in groups. You can ask for force modifications. You can ask for staging, but in majority of the times when the system movements are more than a certain amount, the software itself or the design team will tell us that this case needs to be staged for the sake of comfort, for the sake of engagement, and more predictable movements. One important thing is to make sure to set the expectations correctly, promise less and deliver more. Make sure you educate your patients about efficiency versus speed. The initial discomfort is a very important thing to talk about during the consult visit. Teenagers, 72 hours tops. Adults, tell them about 1 or 2 weeks it's going to suck, be uncomfortable because your tongue has to get used to it. But the majority of the problem that the adults are going to have is with their tongue getting adapted to the system. Tooth sensitivity is the number one thing that goes away within a few days, whether they're kids or adults. Know that if you have used the system before, the new designs, the new shape of the brackets, the coating on the anchorage base, the fact that the arm gets embedded into the bracket and the bracket itself doesn't have any moving parts makes the appliance a lot more comfortable, and engagement and disengagement a lot more easier and less time consuming. My assistants, 2 minutes, 3 minutes tops, they're able to engage or disengage an arch without any difficulty. And my teenage patients, they almost never come back until after the engagement appointment. Usually I see them out 8 to 10 weeks. They normally don't come back for any kind of emergencies or anything like that. Adults might come within the first couple of weeks, but don't expect it to last any longer, as long as they control their hygiene properly, they brush and floss with the system. So you need to talk about all of these with the patient. You have to tell them about the independent tooth movement. You might see things getting worse a little bit before they get better. You have to tell them that you might need to use elastics, so there might be attachments on the outside if needed. And you want to tell them that at the end there's possibility that we will finish with aligners. This doesn't happen necessarily on every single case, but sometimes it does, or majority of the time it does. So you want to make sure they're comfortable with that. All right, I'm running out of time, but about bonding visit, if time is short, there's the peril I have is that don't do everything at that same visit. Give yourself some time until your staff and your team gets familiar with the system. Bond one arch or just bond the brackets. You can engage later. It's going to be okay. And very important is that every time the patients come back, as long as it's been a few weeks, you definitely want to take photos, because the difference between Brava with other systems is that you have to understand how much every single one of the teeth has moved and if they have stopped moving for any reason. And there's no way to know that for sure if you don't without a reference point. And you want your reference point to be the last visit. So take photos, use IPR, always check your contacts. If it's too tight, movements are going to slow down, you can IPR, and the worst that's going to happen is that you over IPR a case, you're left with a hairline space here and there. What is very easy to close with, aligners are very good at closing hairline spaces. So you really don't want to worry about that. So every visit, you want to check your anchors, check your spacing, check your rubber bands, then make sure brackets are not broken and arms are fully engaged. When it comes to finishing, I talked about the aligners, and then there's another important fact when it comes to Brava, and this I have no data to prove it, but you start a first case, you will see it for yourself. When teeth have been through 2 to 4 months of movement with Brava, which technically applies engages all the dimensions all at the same time, the teeth become more malleable. So a movement that might normally take 10, 15, 20 aligners wouldn't take more than 3 to 4 to finish with Brava. This is a very interesting feature. I mean, you get an outcome or response of the teeth as well as you would get it with corticotomies. Like you really get the RAP effect, the rapid acceleratory phenomenon, for a good about 2 months or 3 months after the teeth have moved with Brava. So you make sure you take advantage of that. All right, no matter what I do and how fast I talk, I still run out of time. So let's do cases. This is the case I just finished recently. I think it's amazing, so I'm posting it. I'm showing it to you here. This is a 16-year-old male that came to me with a negative overjet, class 3. There's a slight functional shift, not as much as the overjet, about 2 millimeters. There's asymmetric arches, deep bite, and negative smile arc is present. You can see the lateral ceph, you can see the relationship, you can see how class 3 the patient is. You can see the panoramic X-ray with the roots that are all normal and kind of parallel with each other to begin with. This was so class 3 that I treatment planned him. I gave him surgical option / trial non-surgical, but a little bit camouflage with proclined upper incisors and a little bit reclined lowers. And we said we're going to give it a try. If they liked it, they liked it. If not, surgery is always, of course, an option. The patient just got bonded not too long ago in October of 2023, end of October, beginning of November. It was an eventless bonding. We bonded, and same visit, we placed the attachments on the canines and on the upper first molars for class 3 elastics to help us with the negative overjet. Please note that I didn't put any bite blocks or anything like that. And then the patient came back about a month later in November. The bite has already jumped by proclination of upper incisors. It's kind of a controlled tipping of the upper incisors. The bite doesn't have, he doesn't have a posterior bite yet, so I continue with rubber bands. Within 2 months later, in December, the posterior overbite, contacts are achieved. Case is not completed yet, but we can see that the midlines are on. The lower arch is almost leveled. Everything looks good except we have a little bit retroclined lowers and proclined uppers, which is going to be the finishing relationship given how class 3 the patient is. And then this is 3.5 months into treatment. I go ahead and I don't think I can make this case any better. I take all the brackets out, I debond the case in 3.5 months. And but I'm not happy with how shallow he is, so I'm keeping him on rubber bands. I continued a couple more weeks with that with S6 retainers, and then this is 4 months and 4 days later, which I considered this case to be completed. This was in February, end of February of just about a month ago. This is the final panoramic X-ray. You can see the roots are all parallel. You don't see it here very well, but you can see it down here that the roots are, have their normal anatomy. In the lateral ceph, it shows that the uppers are slightly proclined and lowers are slightly retroclined, which is normal in a case that is so class 3. Yeah. These are side-by-side panoramic X-rays. You can compare them. You can see how much the overbite improved. And then here is the second, the comparison of the lateral cephs. You can see how much improvement we have in the overall aesthetics. Relationship of the teeth. This is what I had simulated for the patient. This is the final outcome that we were able to achieve. This is his smile. That didn't change much because I think he's not mobilizing his upper lips at all. He's only pushing his lower lip down. It will take, you see this common in class 3s that want to hide their relationships or they're not proud of their teeth. So I think within a few months, he should be able to correct his smiling. And this is side by side of before and after. Total treatment time, 4 months and 4 days. This is the second case. She is the 27-year-old female with an anterior open bite history of orthodontic treatment, tongue thrust, slightly, maybe a little bit class 3, some crowding here and there. You can see that there's a biplanar occlusion over here. The effect of tongue thrust. The root structure is normal. There's nothing going on in the pano. Teeth are proclined slightly. I treatment plan her non-extraction with IPR and use of vertical elastics and obviously Brava. We bonded the case in June of 2022, and same appointment I was able to input the attachment for triangle elastics to help me address the vertical component of the treatment. The case gets bonded, and then I do some IPR. 4 weeks later, she comes back. The overbite has improved. We do see slight spaces here and there, which is normal because we're dealing with independent tooth movement. In 3 months progress, she's continuing to wear the rubber bands, and then the open bite is almost corrected, not completely. This one shows it when she's biting down. This is 5 months into treatment. Things are looking a lot better. I still have little gaps here and there, but I'm in the positive overbite territory at this point. 6 months, I keep going. I'm continuing with the rubber bands, and all this time I'm doing nothing. I'm just observing and monitoring and saying hello to the patient, and obviously taking pictures for the sake of presentations and monitoring the progress. Within 8 months into treatment, I don't think I can make this any better with braces. What is left for me to take care of is these minor gaps and minor detailing. Back in the day, I used to leave the brackets on and then scan for aligners, but now I take the brackets off, especially after the Brava Plus. It makes it more, you really don't need the brackets to, scan for aligners. But I left the brackets on and scanned for aligners, and then in about 9 months after bonding, the case is pretty much complete. Alignment is completed. All the gaps are closed, coincident arches, coincident midlines, coordinated arches, class 1 canines. Bite is still a little bit shallow, so in open bites, it's always a good idea to overcorrect. I keep her with the rubber bands for another couple of weeks, and then in 10 months, I'm happy with everything. This is the final outcome. Everything looks ideal, as good as it gets. I go ahead and remove the rubber band attachments. She's on S6 retainers. This is in April of 2023, and you can see the panoramic X-ray. There's no root resorption. There's no tipping. All roots are parallel. All ABO would score this very high, or technically very low discrepancy. Lateral ceph, same thing. You can see overjet and overbite is achieved. There's a single plane of occlusion. There's no open bite, very good vertical control. Patient comes back in 8 weeks for a retainer check. Everything is holding steady. No problems, no issues. Ideal overjet and overbite. And this is just not too few days ago. She came in. She said she was still religiously wearing the retainers every night. She said if they can help her with that, and I added fixed retainers for her. And this is just a few days ago. So still everything is holding steady. No problems with the bite or any kind of relapse so far. This treatment took from here to here 10 months with nothing but one Brias, one Brava, and just a couple of aligners to finish it from here to here. This is the radiographic record side by side. Here's a lateral ceph side by side, simulation versus what actually was achieved, and her smile. I'm gonna, how much time do I have? Let me go through this one case. Well, actually, you know what? Let me do a different case. I did this last time. This case is not finished, but I think it talks to the power of the system very well. It's able to, I'm sorry, I lost my connection to the mouse. Hello.
Dr. Rahimi, while you're getting connection back, I've seen this. It's an incredible case to watch. For those of you that want to stay longer, you're more than welcome to stay, and he can review some more cases. Just letting you know.
Okay. She's a 30-year, 8-month-old female with she has severe spacing. She came to me first, and I referred her to a general dentist to get her cleaning and perio check before she starts braces with us. She came to me with a hopeless upper right 7, severe gap, tongue thrust, perio, teeth, upper incisor centrals had mobility of grade 2. There was tipping. The root of the canine is kind of starting to do fenestration over here. She was a mess. She was also class 2 on the right side. I sent her to the general dentist, and then the general dentist told me that 8 and 9 or upper 1s are hopeless, but you're prepping her for an implant. If you can bring them back, so to recondition the bone, and then we can go ahead and do her implants in the future when these 2 teeth give out. They also extracted the hopeless upper right 7, and then she came back to me. I noticed that there is not much root inside the bone because of her perio, especially on the upper incisors. So Brava would be a good option to utilize because it allows me to control the forces. It allows me to, customize the force system for this patient. She has procline incisors. You see severe overjet and overbite. This is a challenging case. You see bone loss here and there, even localized. You can see here distal to lower left molar. But you know what? When it comes to this kind of situations, if you're able to customize the force system, you can do the best for the patient. So that's the route I took. We bonded the case with Brava in July of 2023. It was an eventless bonding, engaged the 7s, or technically upper right 8, or the wisdom tooth on this side. There was no need for a bite block or anything like that. So the patient left the clinic like that, and then she came back 6 weeks later looking like this. She was worried that because the mobility, she was feeling the upper incisors are mobile, and I told her that you know what, that's a good news because we cannot move them if they're not. The thing that I noticed was that the space has started to close, and here, this is just 3 months later, you can see that The space between upper incisors is now reduced significantly, technically cut in half. Teeth mobility are basically just back to normal, like a normal braces case. And she's in tears of how happy she is because of the improvement in her smile. I mean, we all agree that this is still a huge gap to deal with, but she was emotional of the extent of improvement that she had seen in her smile. This is 5 months later. Again, every time she comes in, she gives me a hug. She's very thankful because this was not something that we could do almost with any other system in this short period of time, given the fact that these upper incisors, just look how parallel they are. I'm going to show you a side-by-side photo of these snapshots, and you will notice that this shows you the power of the biomechanics of this system, that you're technically, these two incisors are basically 4 millimeters or 5 millimeters of roots inside the bone, and we are able to still move them in a controlled fashion parallel to each other in a patient that has perio, that has, a lot going on for her. The space between the 6 and 8 is reduced in half. This space is closing, lower spaces are closing. Everything is moving towards the right direction. Why? Because we had the right forces and moments from the beginning on every single one of those teeth, because it was just designed right, manufactured or engineered correctly. Oh, one thing though, she's class 2 on the left side, on the right side. So I added rubber bands to control sagittal on that end. And then I'm doing nothing. I'm just monitoring it. One mistake I made was that this patient was a stage case, but I hadn't marked it in the chart. So the patient came in here at this time. I scanned her for a second Brava, thinking that because I didn't see too much of a movement from 3 months to 5 month mark, I thought by the next time she comes in, I would have another Brava ready to take it all the way home. And then a month passes, a few weeks passes, and then we're doing inventory. And then I noticed that my staff tell me that, oh, the appliance is here. And then I look at it and I notice that it's the second stage. So we call her back. She comes in, she gets the second stage a month later. I haven't seen her back. She should be coming back very soon, any day, to get the follow-up of the first visit after the second stage of her Brava treatment. But here, look at these roots. Look how parallel these are. Everything is moving the way it's supposed to. Overjet overbite has improved. Proclination has improved. Spaces are much closer. This is before this fenestration is practically gone. The canine root has moved back in. The spaces, the incisors have moved back. There is no increased bone loss or any of that nature. I mean, here, you just look at this. This is about, 20 millimeters of space, and now I'm dealing with about 8, 9. This gap, the whole extraction space, is almost down to 3 millimeters. This 5, 6, 7 millimeter of space here is about 3 millimeters. This another 7 millimeters, 6 millimeters of space here is down to 2 millimeters. On the lower, the incisors are now lined up. They're back in the arch. The rotations are pretty much almost completely corrected. The spaces in the back are closed. And then there's no tipping. Nothing is going on out of the ordinary. And there's a significant improvement here. And this picture speaks for itself. Just how much improvement we got in just a matter of 5 months in such a challenging case.